Perfect. Okay. Good evening. Good evening, everyone. And thank you for joining us at this very late time of the day after your very busy and tiring work day. But we really appreciate your attendance. So thanks for joining us for another episode of Post Monthly Lecture Series. So this is the July lecture of 2025. For anyone who happens to be new here, PO stand for POCUS for Emergency and Acute Care in Resource Limited Settings. And we are a nonprofit organization entirely run by volunteers. And we aim to provide free POCUS training to doctors all over the world. And the topic of July is POCUS in Solomon Islands. PO started reaching out to Solomon Island back in June last year, so just over a year ago. And since then, we've been able to conduct a couple of workshops with the doctors in Solomon Islands. And today, Dr. Emire Meone-Maefiti will present and share some of her experiences of how POCUS has changed or supported her in her daily practice at the National Referral Hospital in Honiara. So please take it away, Dr. Emire.
Good evening, everyone. You can hear me. Thank you, Long, for the introduction, and also thank you to the PILS team for the invitation. Welcome, everyone, again to another PILS lecture series. My name is, Long has already mentioned, is Emire. I'm a general medicine physician at the National Referral Hospital here in Honiara. I was first introduced to the concept of learning how to do echo or POCUS as a mandatory requirement of my specialist training. But it wasn't until 2021, which is the era of COVID, that I actually started using it in my practice. So mostly it was out of necessity when I realized that I could get results faster from doing bedside echo myself rather than from waiting on the imaging team. So today I'll be sharing a bit of our echo journey here at the NRH and what we have seen, what we have learned, and how echo has evolved to become an important extension of our bedside examination. So this talk is aimed at giving you a window into our daily practice and maybe also, hopefully, sparks ideas about how we can continue to support each other in using echo effectively in our settings, which is very resource limited. So where do we work, or where do I work? I'll start with a brief introduction. You can see on the left side of the map is a map of the Solomon Islands, which is a nation that's made up of more than 900 islands. We are scattered across a large area here in the South Pacific. While our population is just over about 700,000, the geography poses major challenges, which is echoed all throughout the Pacific Island countries. Many communities live on remote islands, and these are separated by long boat rides or expensive flights. Sometimes there's no roads or regular transport as well. The healthcare services are unevenly distributed, and most of the country's specialist care and diagnostic tools are centered at the National Referral Hospital in Honiara, where I work. In emergencies, patients from remote islands may take days to reach us if they ever make it. So the picture on the left, is it the right? On the right side of the screen is of the National Referral Hospital. That's the brown roof group of buildings there in the middle. This is the National Referral Center for the whole country. The hospital is a 340 bed capacity hospital, and despite having a CT scanner and radiology unit, accessing these services, as well as a whole lot of other supportive services during after hours or weekends, is still an ongoing challenge. The NRH serves the population of Honiara, which currently sits at around 92,000, but we also are located on the island of Guadalcanal, so where the population is approximately about 160,000. So yeah, combined, we we're saving about almost 250,000 catchment. In the NRH, there are 2 echo machines where a comprehensive echo study can be done. And one is for the adults, so, well, mixed adults, if you want to define it well, because we are looking after children that are aged 13 and above. So one is used for those, and the other one is used for those who are less than 13 years old. And both of these machines operate out of the internal medicine department and the pediatrics. We are fortunate to have the PILS team donate a few handheld butterfly probes on their visit to the Solomon Islands last year, and these have been very useful for our frontline clinicians as well, especially in doing POCUS at the bedside for their patient.
Sorry, Dr. Emire, I just noticed something. Are you able to adjust your camera a little bit downwards so you can see your entire face?
Oh, like this?
Perfect.
Okay. So, what is the value? Does bedside echo really add value to how we treat our patients, or is it just another of those things that, we should leave for the ultrasound specialist to do, seeing how we ourselves are quite stretched out with a number of responsibilities as well. So I want to show you this echo image. It belonged to a 26-year-old athlete, no known medical comorbidities, who was part of the national team and was training for the Pacific Games some years back. The 2 weeks prior to the time this image was taken, he had an episode of syncope while at the game and was therefore brought to the hospital. His vitals on arrival were unremarkable. He was in tachycardic, blood pressure was within normal range, and he didn't have any other complaints when he woke up. He was reviewed at the hospital's emergency department, and his preliminary checks were unremarkable. The department's ECG at that time was not working. So whilst waiting to have an ECG done, he signed out against medical advice and went back to his game, thinking this must have been due to the heat from the sun. Anyways, 2 weeks later, he presented to the hospital again. This time he had high fevers and was quite delirious, was also hypertensive and tachycardic, and was positive for malaria. So he was commenced on antimalarials and then admitted to the medical ward. Initial management that was done was giving him a liter of a bolus of fluid. And because his blood pressure was persistently low, they had started him on some noradrenaline to help the blood pressure. Whilst in the ward, didn't get better, his fevers continued, and he was slipping in and out of consciousness. So this was an image of the echo that we had done when we saw him in the ward. I hope it's coming out okay. Let me know. Are you able to see that?
Yes, perfect.
So this image on the left screen here is a parasternal short axis, parasternal long axis view. It shows significant hypertrophy of the left ventricle. The septum, I hope you can see my cursor, but the septum, you can see how thick it is, and it is more thicker than the posterior wall. But yeah, significant hypertrophy causing obstruction to the left ventricular outflow tract, which you can see the anterior mitral valve leaflet there. The left ventricle is also hyperdynamic with a very small cavity. So he was diagnosed as having hypertrophic obstructive cardiomyopathy, and it was thought that his current illness, that this diagnosis plus our current management was likely causing more harm than good for him. This is a parasternal short axis of his echo, and you can see how thick the walls are, as well as the very small left ventricular cavity. So taking you back to a bit of physiology in POCUS, they depend on adequate preload and filling time. These are two factors that directly affect the degree of the obstruction. And here we have someone who is persistently tachycardic and shortening his filling time. So worsening his obstruction. On top of that, we also think that there might be some sepsis going on. His white cell came back, it was quite high. And sepsis can also cause vasodilation, leading to impacting on the afterload as well, and worsening the obstruction again over his of his LVOT. So this gentleman was quite sick, and after a team discussion, we had decided that our treatment is probably worsening and not helping his general status. We had changed his medication and added a beta blocker and slowly weaned him off the noradrenaline when his blood pressures were holding. Long story short, he was discharged 2 weeks later, got better, was discharged, but he had to forego the trip to the Pacific Games. So this was an example of an echo that helped us to change the management of this patient. The next image is also quite common in our clinics. It belongs to one 15-year-old boy who is a non-rheumatic heart disease and had presented to his usual clinic review date with a complaint of some sore throat, a bit of joint pains, and some fevers, so not so specific symptoms. Anyways, in a clinic setting where we have no beds available and patients are not too sick, sometimes making a decision on their disposition can be quite challenging because some of these patients come so far away and it's very hard to say, oh, you're okay, you take bloods, go home, come back tomorrow and all that. And some of them go and never come back. So what we are using in the clinic is send off the bloods, look at the valves. If the valves look okay with no suggestion of a vegetation, we can send them home and follow up with their blood results later. So while this is not ideal, it was one of the factors that helps us to minimize the risk of mistakenly sending people home. So this was the echo that was done in the clinic. This is the first image on the left upper side is parasternal long axis view. We are only assessing the valves in this protocol. So the aortic valves looks good, as well as the mitral valve. There's nothing sticking on top of that. Also, the aortic valve on the left, right upper quadrant as well. You can also see there's nothing really significant going on here. No thickness, no oscillating thing happening, hanging there off the valve leaflets. This is your pulmonary valve. And this is just a picture capturing your tricuspid valve as well. So sorry, I don't know what that. So is there value? Yes, as these two cases have highlighted, there is definitely value in making echo as an extension of our clinical examination, whether it be in the clinic or the emergency department. It is a very simple test, so non-invasive, immediate, bedside, and we can repeat it as often as we wanted. You don't need a PowerPoint, well, most times at least, or a specific room, or there is no rigid rules on how patients should be positioned as well when you carry out this. So it is the ideal versatile tool for the clinician, and we also love the fact that we can repeat it as many times as we want, especially if we're unsure about what we are looking at and needed an expert review on those pictures. In addition, it also empowers the clinician who doesn't have much to work on to start off with. So it gives them some confidence that they are on the right path when treating their patients, most especially the very sick ones. And because of its versatile nature, it is a very powerful diagnostic tool for us, and can be used not only within the context of POCUS, but also in follow-up comprehensive echo studies later. And like we see in the two cases, it reduces, it facilitates movements of patients. And in the case of the second case, it avoids admission and reduces the bed block that we also routinely face on a regular level here in the Solomon Islands. So definitely there is value in echo for us. So just a brief background of where we have been in the past with our echo. In the past, so past being more than 10 years ago, we only have one machine, which is located within the imaging unit, and only one radiologist who is the only trained person for it. He was the only radiologist for the whole country as well, so there were a lot of competing priorities, and echo most times takes the backseat unless it's suspected emergency situations such as a tamponade or something equally similar. So access was quite a challenge for us, and many patients were clinically diagnosed only and never actually got an echo, which is a big, huge problem for us, considering the fact that we have a huge burden of rheumatic heart disease in our country. So its use in critical care also was non-existent, and for a lot of doctors, it was such a foreign concept that no one can comprehend, a doctor using echo, let alone POCUS, outside the realm of radiology. So in the past as well, past now being about 10 years ago, less than 10 years, we had a machine that was donated in 2015, and this was old and huge and was very hard to move around. But that marks the start of our echo journey as part of clinical routine clinical practice. At the beginning, there were only two gen med physicians, and learning how to use and navigate the machine was an added responsibility on an already full schedule. Also, at that time, online learning was also a foreign concept with limited internet connectivity as well. So it wasn't a big thing at that time, with smartphones being slowly introduced in the country. So that machine sat for a while. But we were fortunate to have visiting cardiologists who came to the country and were able to teach the basics of echo over the next 2 to 3 years. And for the next few years, our use of echo, I think, was just mostly as POCUS only, and we've never done comprehensive studies on our patients for that. So now we come to echo, our current standings at the moment. So where have we reached in our echo journey so far? This is an image that was done by one of our trainees as well in the clinic, a 20-year-old male that was a known case of mixed mitral valve disease, and taking monthly penicillin for the last 5 years. So he came for another routine review, but was noted to have cough for the last month with hemoptysis and weight loss and poor appetite. He also gave a history for intermittent fevers as well, and on examination was noted to be not only the tachypneic, but has low-grade fever. Blood pressures were okay. He was slightly jaundiced with big tenderness around the epigastric area. So this was the echo that was done when he came into the clinic at that time. On the right here, on the left of the screen is, so this is another parasternal long axis view. You have your right ventricle on the top with the interventricular ventricle underneath that. And behind that, at the bottom inferior to that, is a hypoechoic area that it's not clearly shown here, but if you follow it up, it should be just above your descending aorta, which is somewhere around there. If you look at the mitral valve as well, it also looks a bit dodgy, with thickened anterior mitral valve leaflets, as well as the posterior valve leaflet is also thickened and looks a bit restricted. And there was concern for vegetation as well on that anterior mitral valve that was floating up and down there. So anyways, the blood cultures were taken for this patient and sent off. We also collected sputum, and we had sent that off as well. If you see, this is the next picture on the right top here is your apical four-chamber view, and we can also see that area of hypoechoic around the left ventricle there. And the one on the bottom is your is a picture of the IVC. So tamponade was also another concern, especially when there is tamponade physiology being seen on the echo. This boy was started on empirical antibiotics and got admitted to the ward. The blood culture results came back about 36 hours, 72 hours later. They were growing staph aureus. But the sputum was also positive for TB as well. So he was started on both antibiotics as well as treatment for tuberculosis, with steroid added to his treatment. So that is where we are now. This next slide aims to highlight what we have done so far. So from the previous slide that you see, now we are able to do echo. Because of the machine that we have, we're able to do it in the outpatient, in the wards, as well as in the clinic. So from 10 years ago, our current status at the moment, we still have one machine serving the whole country, and this is for a bit of more comprehensive echo study as compared to the POCUS and basic echo that we do. So still one machine, not much development there, but now we have a number of probes thanks to the PELS team that came last year, and because of this, because of the training plus the number of handheld probes that we've had, it has made basic echo being sort of extra easily accessible to our doctors in the front line as well as in the provinces. We also have a number, so because we have a good number of doctors that can do that, now this has caused more expanding interest in this area, and people are now becoming more interested and wanting to, we're witnessing, a very big amount of interest among the doctors who are now no longer, viewing echo as something to be relegated to the radiology department only. And because the echo machine is now within the unit, it has become more accessible to us and to use and incorporate into our routine rounds and teaching sessions. And I think one of the new aspect of echo use for the hospital that is we are now sort of using more and more is within the space of critical care, where we now rely a lot on our echo to guide our management in those who are critically ill. So we are still limited by a lot of things, and one of them is the number of machines. More than 70% of our population lives in the rural and remote area. So they cannot make the long distance to travel to us for an echo study. So having one echo machine situated in the National Referral Hospital only is not enough, and we still need to advocate for more machines. In terms of human resources, we do not have the manpower at the moment, and we cannot assign dedicated individuals to focus on this solely. So mentorship and local training of candidates can become sort of buried in the long list of competing priorities on the ground. And because of this also, the advancing individual skill sets really depend on highly motivated individuals who have to take the extra time to, self learn a lot of things. We're also limited by the lack of storage system that we have. So after the training with Pearls, we are able to access and use the Butterfly cloud storage as part of the storage for us. But a lot of our comprehensive eco studies cannot be stored. We've had so many incidents of storage crashes, and we've lost a huge number of eco studies over the last 5 years, and it's still something that we're trying to work hard on, that will sort of put this as a priority for the country. So looking towards the future, I think our main challenge going forward is building sustainability of this service for the whole country. The easy accessibility that we now enjoy should be consistent and sustainable. And this, sorry, what did I do? And what was I saying? So this can only happen if ECHO is viewed not as a one department or one person responsibility, but should become the expected fabric in all our clinical settings. Of course, to achieve all this, we need to set out priority areas, outlining what level of ECHO training we want for the different levels of care throughout the country. We still need to improve access to equipment. We also need to introduce structured reporting that not only sprouts out numbers, but are clinically relevant for the person on the receiving end. And possibly the last thing that we also need to consider is creating a learning pathway for all doctors that all our junior doctors that come out of internship, that they should all be aware of at least basic echo and POCUS, so that this can help them when they go out in our rural provinces and settings. But yeah, so I think that's basically my talk for today evening. I hope that you are able to appreciate the journey that we have come thus far in our ECHO here in the Solomons. Thank you.